Welcome to the deep dive. This is where we take the sources you send us on a topic you're curious about, and we really get into it.
Yeah, the idea is to pull out the key stuff, maybe some surprising facts,
Yeah.
and give you a solid handle on the subject, with you having to read through piles of material yourself.
Exactly. And today we're diving into levofloxacin. You send over a great mix of info, and we're going to track this antibiotic from, well, its beginnings right up to where it stands now.
We'll be looking at how it actually works inside the body, how it's manufactured, and definitely getting into some of the controversies that have popped up around its use over the years.
Right. Antibiotics are something most of us have probably encountered, maybe taken ourselves. But I think this look at levofloxacin will go, well, quite a bit deeper than just that surface awareness.
We're talking the science behind it, the development path, and a regulatory story that's, frankly, got some pretty significant twists. So, yeah, let's get started.
Okay, so antibiotics. It's kind of amazing to think that we didn't invent the core concept, right? Bacteria have been doing this for ages.
Oh, billions of years, they've been producing these compounds to fight each other. We mostly just discovered what they were already making and figured out how to use it.
And levofloxacin fits into that discovery timeline later in the 20th century, patented in 1987, I see, and then got the FDA green light in the U.S. in 96.
That's right. And that timing puts it in a, pretty active period for antibiotic development. It's what we call a third-generation fluoroquinolone.
Third generation. What does that typically mean in antibiotic terms? Better, broader?
Usually, yeah. It often means improvements over the earlier drugs in that same class. Maybe it works against a wider range of bacteria, or maybe it's absorbed or distributed in the body more effectively, that sort of thing. It signals an evolution.
Interesting. And we even have this level of detail from a European patent, EP 1451194B2. It's about making levofloxacin hemihydrate. Looking at the dates and related filings, it really shows the technical slog involved.
It really does. That patent gets into the nitty-gritty chemistry needed to get a stable, effective form of the drug, the hemihydrate in this case, making sure it's consistent and pure.
But there was a little hiccup with that patent.
Yeah, a small administrative one, it seems. It actually lapsed in Italy back in 2006. Looks like it was potentially due to translation issues or maybe unpaid fees.
Huh. So even with groundbreaking science, you still have paperwork hurdles.
It's a good reminder, isn't it? The whole process involves more than just the lab work. Regulatory and administrative steps are crucial. You wonder if that lapse maybe affected costs or availability there early on compared to elsewhere. Probably not hugely, but it's possible.
Okay, so moving from the patent office to the pharmacy shelf, essentially. Where does levofloxacin actually get used in medicine? What's it approved for?
It's got a fairly wide range of FDA-approved uses. It tackles some pretty serious stuff like nosocomial pneumonia, that's the kind you might pick up in a hospital.
Right.
And also community-acquired pneumonia, the kind you get, well, out in the community.
Okay, those are definitely significant lung infections. What else?
It's also approved for skin and skin structure infections, SSTIs. That includes both complicated ones and the more straightforward types. And chronic bacterial prostatitis, which is a persistent infection in the prostate gland.
Got it. But I think I saw some notes about limitations for certain other common infections, bronchitis and sinusitis.
You did, and that's really important. For acute bacterial exacerbations of chronic bronchitis ABECB, and also for acute bacterial sinusitis, the FDA guidance is now quite clear.
Which is?
Levofloxacin and fluoroquinolones generally should only be used for these conditions if there are no other appropriate antibiotic choices available.
Why the restriction?
It comes down to the risk of serious side effects, which we'll definitely get into more detail on later. Regulators decided the potential risks outweigh the benefits for these often self-limiting infections when other, potentially safer options exist. It's that risk-benefit balance.
That makes sense. A crucial calculation in medicine. Now, I was also a bit surprised to see it listed for some really serious, maybe less common things.
Yes, absolutely. It has a critical role in treating inhalational anthrax after exposure. That applies to both adults and kids, actually, down to 6 months old, though dosages differ based on weight.
Anthrax, wow.
And similarly, it's approved for treating plague, both the pneumonic and septicemic forms, and also for preventing plague after exposure, again in adult and children 6 months and up.
So life-threatening situations, how do they even test efficacy for something like plague or anthrax? You can't exactly run standard human trials.
Precisely. For ethical reasons, a lot of the efficacy data for these specific indications comes from animal studies. You extrapolate how well it works in controlled animal exposures to understand its likely benefit in humans. It's a necessary approach for these rare but potentially devastating diseases.
Fascinating ethical navigation there. And it's also used for more common infections too, right? Like UTIs.
Yeah. Urinary tract infections, yes, including acute pyelonephritis, which is a kidney infection specifically. And just as a side note, there's an eye drop formulation for bacterial conjunctivitis, pink eye.
Okay, so a real workhorse in some ways, but then there was this huge news I saw referenced regarding tuberculosis. That sounds potentially massive.
It really is, very significant. A major clinical trial, results published just recently in the New England Journal of Medicine, January 2025, it looks like, showed something pretty remarkable.
What did they find?
They found that a 6-month, once-a-day oral regimen of levofloxacin significantly cut the risk of people developing drug-resistant TB. And even more impressively, it nearly halved the risk of developing multi-drug-resistant TB, or MDR-TB. That applied to both adults and children.
Halved the risk of MDR-TB. With a 6-month oral course, that sounds like a game changer.
It absolutely could be. Think about it. MDR-TB treatment traditionally involves long, difficult regimens, sometimes 2 years or more, with toxic drugs and often lower success rates. A shorter, effective oral option like this, that could dramatically improve outcomes and make treatment feasible in many more settings globally. It's a huge potential step forward against a really tough disease.
Wow. Okay, so we know what it treats. Let's get into the how. How does levofloxacin actually stop these bacteria? What's the mechanism?
So as we said, it's a fluoroquinolone antibiotic. Its main job is to mess with 2 absolutely essential bacterial enzymes. They're called DNA gyrase and topoisomerase 3.
Right, enzymes involved in DNA.
Exactly. Think of them as the bacteria's vital DNA toolkit managers. They're needed for basically everything DNA related. Copying the DNA, replication, reading the DNA to make proteins, transcription, repairing any damage, and rearranging bits of DNA, recombination, all fundamental processes for the bacteria to survive and multiply.
So levofloxacin jams those tools.
Pretty much. By inhibiting these enzymes, it throws a major wrench into the works. The bacteria can't properly manage their DNA, vital processes grind to a halt, and ultimately the bacterial cell dies. It's a targeted strike at the core of their operations.
Okay, makes sense. So that's what the drug does to the bug. What about what our bodies do to the drug? The pharmacokinetics and pharmacodynamics. You described kinetics as body to drug and dynamics as drug to bug.
That's a great way to remember, yes. Pharmacokinetics is all about absorption, distribution, metabolism, excretion. How the drug gets in, moves around, gets broken down, and gets out.
And we have data on that, like Cmax, Tmax.
Right. The FDA label gives us those key numbers. Cmax is the peak concentration the drug reaches in your blood. Tmax is how long it takes to hit that peak. AUC, or area under the curve, tells you the total drug exposure over time. And half-life is how long it takes for the concentration to drop by half.
And these numbers change depending on how you take it: pill, liquid, IV, and the dose.
Exactly. A 750 milligram dose will generally give you a higher Cmax and AUC than a 250 milligram dose. An IV injection might reach its peak faster, a shorter Tmax, than an oral tablet. And individual factors matter too. Things like your age, your gender, and especially how well your kidneys are working can influence these parameters.
So doctors need to consider all that when dosing.
Definitely. A higher Cmax might be needed to quickly knock down a severe infection, while maybe a longer half-life is good for allowing once-daily dosing, which helps people stick to the treatment. It informs the strategy.
What about distribution? I saw something about protein binding.
Yeah, levofloxacin is about 30% bound proteins in your blood plasma. That means the other 70% or so is free, unbound, and available to travel into tissues and actually fight the bacteria.
Okay. And hydration is important too.
Very important. Levofloxacin is mainly cleared out by the kidneys into the urine. If you don't drink enough fluids, the urine can become too concentrated, and the drug might form tiny crystals. That's called crystalluria. It's potentially harmful to the kidneys, so staying well hydrated is key.
Good practical tip. Now, those other terms, FC max MIC and FAUC 24HMIC. Looks like alphabet soup. What do they tell us about effectiveness?
Ah, yes. That gets into the pharmacodynamics, linking the drug concentration to its effect on the bacteria. MIC stands for minimum inhibitory concentration. It's the lowest drug concentration needed to stop a specific bacterium from growing in a lab test.
Okay, the minimum needed.
Right. So FC max MIC compares the peak free drug concentration, S means free, unbound drug,
Thank you.
to that minimum requirement. It's like asking, Was the initial hit strong enough compared to what's needed?
And FAUC24HMIC.
That compares the total free drug exposure over a 24-hour period to the MIC.
Yeah.
It's more about sustained pressure. Was the drug level high enough for long enough over the day?
So different measures of hitting the bacteria hard enough?
Exactly. And for certain bugs, like Streptococcus pneumonia, which causes pneumonia, studies like one mentioned in healthy Chinese volunteers suggest you need to hit certain targets for these ratios to get the best clinical results. For example, maybe an FC max MEC of 5 or more, or an FAUC24 HMIC of 30 or more, seems to predict successful treatment. It helps determine optimal dosing regimens.
That clarifies it nicely, thanks. So we understand how it works. How is it actually made? Where does Levaquin, the brand name, come from?
Well, the information we have points to the Levaquin injection being manufactured for the OMP division of Ortho-McNeil Pharmaceutical, which is part of Johnson & Johnson, by Janssen Pharmaceutica NV, located in Belgium.
So manufactured in Belgium, a global product right from the start.
Seems so. And it comes in different forms for hospital-use, single-use vials, pre-mixed IV bags, and flexible containers, various concentrations and volumes. Standard stuff, but it needs careful handling, like storage at controlled room temperature and protection from light to maintain stability.
And those patents we talked about earlier, like the European one, EP1451194B2, they describe the actual chemical steps involved.
Precisely. They detail the how-to for making that specific levofloxacin hemihydrate form. There are also other patent entries, like one found via Google Patents and another link on PatSnap Eureka from China, CN 10097216114A, related to preparation methods.
What does that suggest? Ongoing tweaks? Generics?
Could be both. It suggests ongoing work to maybe refine the process, make it more efficient, or perhaps reflects methods used by generic manufacturers after the original patents expired. The existence of generics is a big factor in its economic story, of course.
Right. Which brings us squarely to maybe the most complex part of levofloxacin's story. The regulatory side, the legal issues, the controversies. It hasn't exactly been smooth sailing, has it?
No, far from it. After that initial FDA approval in 1996, the subsequent years saw a steady drumbeat of safety concerns and increasingly strong warnings from regulatory bodies like the FDA, specifically about the entire fluoroquinolone class, which includes levofloxacin.
What triggered these? What were the first major flags?
The first really big one was about tendons. In July 2008, the FDA mandated a boxed warning, that's their most serious type of warning, highlighting an increased risk of tendinitis and, more worryingly, tendon rupture.
Tendon rupture. That sounds serious.
It is, especially concerning the Achilles tendon, but others too. This risk was found to be higher in older patients, those taking corticosteroids, and transplant recipients.
And the warnings didn't stop there.
No. In February 2011, the boxed warning was updated again. This time, it added the risk of making muscle weakness worse in people who already have myasthenia gravis, which is a neuromuscular disorder.
Okay, so tendons, then myasthenia gravis. What came next?
Nerves. In August 2013, the FDA required label updates about the potential for irreversible peripheral neuropathy.
Irreversible nerve damage.
Yes. Symptoms like pain, burning, tingling, numbness, weakness, potentially starting soon after beginning the drug and possibly becoming permanent. That was another major red flag about potentially long-lasting harm.
That's a cascade of serious warnings. Then there was an FDA meeting specifically about its use for common infections.
Exactly. In November 2015, an FDA advisory committee met. They specifically looked at using fluoroquinolones for acute sinusitis, acute bronchitis exacerbations, and uncomplicated UTIs. The concern was the growing number of reports about multiple, disabling, and potentially permanent side effects happening together, affecting tendons, muscles, joints, nerves, and the central nervous system.
And what did the committee conclude?
They basically concluded that for these less serious infections, where other treatment options are available, the serious risks associated with fluoroquinolones generally outweighed the benefits for most patients.
That feels like a real turning point in how the drug was viewed.
It was, and it led directly to stronger actions. In July 2016, the FDA approved even stronger warnings, emphasizing these disabling and potentially permanent side effects. The recommendation became reserve fluoroquinolones for patients with these common infections who have no other treatment options. Limit their use drastically in these situations.
And Europe followed suit.
Yes, the European Medicines Agency, the EMA, conducted its own review around the same time. They also came out with new restrictions or precautions due to, as they put it, very rare but disabling, long-lasting, or irreversible side effects, primarily involving the musculoskeletal and nervous systems, but also psychiatric issues and sensory problems. So a transatlantic consensus was emerging about significant risks.
With all these warnings piling up, it's probably not surprising that legal action followed.
Not surprising at all. Thousands of lawsuits have been filed against the manufacturers, companies like Bayer, Merck, Johnson & Johnson subsidiaries.
What was the main argument in these lawsuits?
The core allegation typically was failure to adequately warn. Plaintiffs argued that the companies knew or should have known about these serious risks sooner and didn't properly inform doctors and patients through the drug's labeling.
So claims like negligence, failure to warn.
Yes, those were common claims. Negligence in testing or labeling, strict liability, arguing the drug was inherently defective or unreasonably dangerous, and sometimes even fraud, alleging intentional downplaying of the risks.
And did the focus of these lawsuits change as the FDA warnings evolved?
Absolutely. You can track it. Early on, many lawsuits centered on tendinitis and tendon ruptures, matching that first 2008 boxed warning.
Makes sense.
Then, after the 2013 warning about peripheral neuropathy, that became a major focus of litigation. Nerve damage claims surged.
And more recently?
More recently, especially after general FDA warnings in 2018 about fluoroquinolones and the risk of aortic aneurysms and aortic dissections, basically, dangerous bulging or tearing in the body's main artery. Those severe cardiovascular events have become a growing area in the lawsuits. Again, often with the claim that manufacturers had signals about these risks earlier than they disclosed them fully.
It paints a picture of a powerful drug, undoubtedly useful, but one where the understanding of its potential downsides has grown significantly over time.
That's exactly it. The risk-benefit calculation has shifted dramatically, especially for those less severe infections. The clear message now is caution and reserving these drugs for situations where they are truly necessary, and the benefits clearly outweigh these now well-documented risks.
And communication channels like the FDA's MedWatch system or reports from places like CIDRAP at the University of Minnesota, they're crucial for getting this safety info out.
Absolutely critical. Getting these updates to doctors and pharmacists on the front lines is essential for changing prescribing practices and protecting patients.
This whole regulatory and legal saga must have had economic consequences, too.
Oh, certainly. On the one hand, the arrival of generic levofloxacin after the patents expired would have driven down the price significantly compared to the brand name Levon. That's standard market dynamics.
But the warnings probably dampened demand.
Exactly. Studies have looked at prescribing patterns before and after these major FDA warnings, and they generally show a noticeable decrease in fluoroquinolone use, particularly for those infections where they are no longer recommended as first-line therapy. That directly hits market share and revenue.
And this ties into a bigger issue in the antibiotic world, doesn't it? The pipeline for new drugs.
It does. Experts like Dr. Brad Spellberg have been quite vocal about this. There's a real concern that large pharmaceutical companies are pulling back from antibiotic R&D.
Why is that?
It's a tough combination. The science itself is difficult. Discovering genuinely new classes of antibiotics is hard. The economics aren't great. Antibiotics are typically taken for short periods, unlike chronic disease meds, and resistance can shorten their lifespan, making it hard to recoup massive R&D costs. Plus, some argue the regulatory environment, while necessary for safety, can also be challenging for developers.
So companies might see it as less profitable than other areas.
That seems to be the case. When a major player like Pfizer significantly scales back its antibiotic research, as happened a few years ago, it sends a worrying signal. We desperately need new antibiotics to combat resistance, but the current market doesn't always incentivize their development effectively. It's a real public health challenge.
A very sobering point. Okay, lastly, let's think about the cultural impact. How has levofloxacin and the broader story of antibiotics and resistance influenced public perception and behavior?
Well, there's definitely increased awareness, partly thanks to campaigns like the WHO's Global Action Plan on Antimicrobial Resistance. People hear more about superbugs.
But understanding is still patchy.
Very much so.
Yeah.
WHO surveys across different countries consistently show significant public misunderstanding. For instance, lots of people still think antibiotics work against colds and flu, which are viral, of course. And a worrying number believe you should stop taking antibiotics as soon as you feel better, rather than completing the full course. These kinds of beliefs directly contribute to the rise of resistance, which undermines the effectiveness of drugs like levofloxacin for everyone.
And the safety warnings and lawsuits we discuss that must also shape how people view these drugs.
Unquestionably. The media coverage around tendon ruptures, nerve damage, and other serious side effects associated with fluoroquinolones has likely created a sense of caution, maybe even fear among some patients and prescribers. It becomes part of the narrative around these drugs.
So it's this complex picture, a drug that's vital for treating really dangerous infections like MDR-TB or anthrax,
Absolutely critical in those cases.
but also one that carries significant risks and is now advised against for more common ailments, all playing out against this backdrop of growing resistance and public confusion.
It really encapsulates the double-edged sword of powerful medicines, essential but requiring careful, informed use and ongoing vigilance. It highlights the need for really clear communication between doctors and patients about why an antibiotic is needed or why perhaps it isn't and what the potential downsides are.
So wrapping up our deep dive on levofloxacin, we've traced its path from discovery and patenting.
Explored its wide range of uses, from common UTIs to life-threatening plague, and its potential new role in TB.
Delved into how it works at the molecular level, disrupting bacterial DNA,
Looked at how it's made, how our bodies handle it, and what makes it effective.
and spent significant time on the really crucial regulatory story, the warnings, the lawsuits, the shifting understanding of its risks.
Which in turn have shaped its economic life and its cultural perception, tied into the larger story of antibiotic resistance.
It really shows that even a single drug can have such an intricate history and ongoing impact.
Definitely not just a simple pill. It underscores that constant balancing act in medicine, weighing the profound benefits against the potential harms.
And it really brings home the importance of using these precious resources wisely. Maybe prompts you, the listener, to think about antibiotic stewardship and perhaps check out some resources, like from the WHO on antimicrobial resistance.
Yeah, and it leaves us with a critical question to ponder. With potent tools like levofloxacin that can save lives but also cause harm, how do we collectively, the medical world and all of us as individuals, ensure we're using them in the best possible way? How do we maximize the good, minimize the bad, and preserve their power for the future when we'll undoubtedly still need them?